Abdominal aortic aneurysm.
An abdominal aortic aneurysm results from damage to the medial layer of the abdominal portion of the aorta. Aneurysm commonly results from atherosclerosis, which over time causes a weakening in the medial layer of the artery. Continued weakening from the force of blood flow results in outpouching of the artery and formation of the aneurysm. The aneurysm may then cause a rupture, leading to hemorrhage, hypovolemic shock, and possibly death. There are 4 types of abdominal aneurysm: dissecting, false, fusiform, and saccular. Dissecting aneurysm is, the vessel wall ruptures, and a blood clot is retained in an outpouching of tissue. The false aneurysm is, pulsating hematoma, results from trauma. Fusiform aneurysm is bilateral outpouching. Saccular aneurysm is, unilateral outpouching. What are the causes of abdominal aortic aneurysm? Atherosclerosis, which weakens the aortic wall and gradually distends the lumen. Congenital defect, such as coarctation of the aorta. Hypertension, infection, Marfan syndrome, syphilis, trauma. What to look for when assessing a patient with abdominal aortic aneurysm? Abdominal mass to the left of the midline on deep palpation. Abdominal pulsations in the periumbilical area. Bruits over the site of the aneurysm, possible systolic bruit over the aorta on auscultation. Commonly asymptomatic. Diminished femoral pulse. Look for signs of shock when caring for clients with abdominal aortic aneurysm. Lower abdominal pain. Lower back pain. Lumbar pain that radiates to the flank and groin. Systolic blood pressure in the legs, that's lower than that in the arms. When assessing for signs and symptoms of abdominal aortic aneurysm, remember to jog a few laps. Lumbar pain that radiates to the flank and groin, this is a sign of imminent rupture. Abdominal tenderness on deep palpation, this is a possible sign. Pulsating mass in the periumbilical area. Systolic bruit over the aorta, this is a possible sign. These are the diagnostic test results and what it will tell you. Abdominal computed tomography scan or abdominal ultrasonography determines the aneurysm size, shape, and location. Aortography shows the condition of vessels proximal and distal to the aneurysm and the extent of the aneurysm. However, this test may underestimate aneurysm diameter because it shows only the flow channel and not the intraluminal clot or dilated walls. Chest X-ray. Anteroposterior and lateral X-rays of the abdomen can detect aortic calcification, which outlines the mass in at least 75% of patients. ECG differentiates aneurysm from MI. Nursing diagnosis. Acute pain, anxiety, ineffective tissue perfusion, peripheral. Risk for deficient fluid volume. What are the treatments for abdominal aortic aneurysm? Bed rest. Abdominal aortic aneurysm resection. Usually, abdominal aneurysm requires resection of the aneurysm and replacement of the damaged aortic section with a Dacron graft. These are examples of drugs used to treat abdominal aortic aneurysm. Analgesic, oxycodone, OxyContin. Antihypertensives, prazosin, minipress, nitroprusside, nitropress, nitroglycerin. Beta-adrenergic blocker, propranolol, Inderal, metoprolol, low-pressor. If rupture occurs, there's no time to lose. Get the patient right to surgery. Large aneurysms or those that produce symptoms involve a significant risk of rupture and require immediate repair. If the aneurysm appears small and asymptomatic, the practitioner may delay surgery, opting first to treat the patient's hypertension and reduce risk factors. Keep in mind, however, that even small aneurysms may rupture. The patient must undergo regular physical examinations and ultrasound checks to detect enlargement, which may indicate imminent rupture. Endovascular grafting may also be used to repair an abdominal aortic aneurysm. In this minimally invasive procedure, the surgeon will insert a catheter with an attached graft through the femoral or iliac artery and advance it over a guide wire into the aorta, where he'll position it across the aneurysm. A balloon on the catheter expands, affixing the graft to the vessel wall and excluding the aneurysm. Here are the interventions and rationales you can do as a nurse. Assess cardiovascular status, and monitor and record vital signs. Tachycardia, dyspnea, or hypotension may indicate fluid volume deficit, caused by rupture of aneurysm. Monitor intake and output and laboratory studies. Low urine output and high specific gravity may indicate hypovolemia. Observe the client for signs of hypovolemic shock from aneurysm rupture, such as anxiety, restlessness, severe back pain, decreased pulse pressure, increased thready pulse, and pale, cool, moist, clammy skin, to detect early signs of compromise. Gently palpate the abdomen for distension. Increasing distension may signify impending rupture. Check peripheral circulation, pulses, temperature, color, and complaints of abnormal sensations. To detect poor arterial blood flow. Assess pain. To detect enlarging aneurysm or rupture. Administer medications, as prescribed. To reduce hypertension and control pain. Encourage the client to express feelings such as a fear of dying. To reduce anxiety. Maintain a quiet environment. To control blood pressure and reduce risk of rupture. Here are some topics you can teach to the patient. Explanation of the disorder and treatment plan. Medications and possible adverse effects. Signs and symptoms of decreased peripheral circulation, such as change in skin color or temperature, complaints of numbness or tingling, and absent pulses. Activity limitations, including alternating rest periods with activity, and adhering to prescribed exercise and diet regimen.